All right, this meeting is being recorded. Are there any objections to this meeting being recorded today?
No.
No.
All right, great. So I'm going to pull up the agenda. We can go over it and see if there are any requests for modifications, and then we can get started. So at our last meeting, we provided an overview of the committee's work to date and went over the proposed plan designs and how they align with the priorities that the committee has established, and then opened up the opportunity for folks to submit comments. And we got a wide array of comments, some of which we'll go over today. There were some questions that were submitted, and OSI is in the process of providing some feedback on those for the committee to review, and would be happy to share that publicly as well once the committee has had a chance to consider those responses. So the first item on the agenda today is the approval of the agenda. Next, we'll move to introduction of committee members, a review of key topics, and for today that will be the review of comments and then discussion on those comments. I think during that section of the meeting, we'll encourage folks who submitted these comments to be able to provide input at that time as well. And then opportunity for the committee to have Q&A and requests for testing impacts of the requested modifications that we received. We do have some folks from Wakely Consulting who are helping the committee out with this project, and I think they'll be able to join for part of today's meeting, and the recording will be shared with them as well. They'll be helping us actually make these changes to the actuarial value calculator, and then help us to assess some of the changes that are being requested. And then from there, we'll talk about next steps in this process. Any questions or concerns or anything we should make sure to include on this agenda that may not be there?
Yeah, I don't know if you can see my hand raised, but
Yes.
Oh, okay. Before we approve the agenda, I just wanted to clarify whether it's Wakely or where it might fit on here, but I do want to discuss how some of the policies reflected in this proposed standardized plans could impact premium prices, and how we're going about kind of assessing that, at least in, estimated general terms, and what that might mean and where that fits in. Is that something we're discussing today or at our December meeting? But I think it's important for us to address.
Absolutely, and we do have some folks from Wakely on, so I don't know if Julie or Ksenia, you want to speak to the capabilities around that?
For me, Colin, right now, it's just, is it part of today's agenda? And if not, when are we going to do that?
It is not on the agenda today, but it is something that Wakely is able to do, and I'll ask them to just let you know what they're able to provide for that.
And the next question is I have up on my screen the agenda that you had sent, and there was something on market overview that's not here now.
I think that was intended to be for the following meeting. I didn't realize that was on. It's not on the one that I have today. Sorry.
Okay. All right. Well, with that, I move to accept the agenda.
Great. And is there a second?
Colin, this is David, a second.
All right, great. And I think then before we jump in, either Julie or Ksenia, if you wouldn't mind letting the committee know about the capabilities that you all have for being able to provide that data point of potential impacts.
Sure. Hi, everyone. Can you hear me?
Mm-hmm.
Yes.
My name is Ksenia Whittel. I'm a consulting actuary with Wakely and assisting Colin and you all with the standardized benefit plans. Certainly the impact on the premiums is something we did discuss with Colin last week, and there are couple of ways we could address that and provide a range. However, it is very much up to issuers in how they set pricing and their pricing methodology. So there could be a significant variation in those impacts. So I just want to make sure that we recognize that. So we can certainly provide some guidance, but recognizing that there's still quite a bit of leeway that issuers have when they develop premiums.
Yeah, I think for me, it would be kind of obviously just sort of rough and maybe even as a percentage of current premiums or, something just to get a ballpark as we begin to think about what's available and the affordability fund and all of that.
Okay, yeah, and we'll certainly give it more thought as well, and yeah, come up with a solution.
Ksenia, this is Annie Sapon. Hi, how are
Hi,
you?
Annie. Yeah, good to see you. I'm
Good
well.
to
How are
see you. Good. So also, I would like to see some information just like on the actuarial value of the plan and like where, if you guys think it's going to lean high or lean low within, either any of the brackets. Because you know how you can look at an actuarial value and it has a lot of slush, which would just, as far as benefit configuration. And so if we could, understand that piece of it as well. Because you can see a plan that is has an actuarial value of 86, but it's actually performing closer to like a 90% AB. So just
Sure.
be
So I
interested.
think just to clarify, Annie, I think what you're getting at is the potential difference between the federal actuarial value and the actual
Yes.
pricing actuarial value.
Yes.
Sure.
Yes.
Sure. Yeah.
Because that comes.
Mhm.
Yeah. Because that comes into play in the premiums as well, right? Because it's like it can drive tons of utilization, which ultimately leads to increase in premiums. So that would be great. Thanks.
Okay, makes sense.
Ellen, I think you're muted.
I keep on doing that. Sorry about that. Any other questions from the committee on that point? All right. Thank you, Ksenia. All right, so now we will provide a review, and I see that there are a couple folks on here who had submitted comments. Let's see, and if they are on, I'll certainly give them an opportunity if they want to speak any more to what was submitted. Are you able to see my screen?
Yes.
Yeah.
Great. So gonna go through these one by one and let you know what was submitted. The full comments were transmitted via email at the end of last week, and OSI has had a time to review all of those, and we'll provide that written feedback on some of those questions later this week. So the first comment we received was from Debbie Ryder. She is a health insurance producer in the state and has noted a trend of plans shifting more and more towards coinsurance, and that consumers are frustrated by the lack of copay options, even with the turquoise plans reducing the overall cost exposure. And she is worried that people might be avoiding care because of this and supports standardized plans with only copays as the committee is moving toward that option. And I don't think that we have Debbie on today. I think that she said she was working with clients today. Yeah, I do not see her on. We also received a comment from Dr. Barbara McEnany, who is a local healthcare provider and owns a practice, and she offers health benefits to her employees. I believe she said she has 250 employees, and their plan is self-insured. So I think most folks are familiar with this, but the risk that is taken on by the business itself rather than the insurance plan. And she noted that because she has flexibility with how she designs her health plans for her employees, that a couple years ago she eliminated copays for physicians visits and medications, and specifically said that she didn't want to put a barrier in front of what her employees need for their health services, and noted that her costs haven't gone up and her employee premiums haven't gone up in that time. So That's one, I think, snapshot into a business that worked with some of these plan design and actually went, I think, a little further than what's being proposed here, and actually completely eliminating copays for certain services, and at least for her employee population, found that there wasn't a premium impact in that period of time. We also received comments from the New Mexico Center on Law and Poverty, which is an advocacy group. And they noted a recent survey that they performed with their partners found that in New Mexico, 56% of people have said that they've sacrificed medical services in the past 2 years because of costs. So I think really focusing in on that out-of-pocket issue and barriers to care. They also specifically commented on coinsurance and that it is unpredictable for families, even when people can plan out the care that they need in a given year. And they said copays can provide individuals and families with much more transparency and predictability when they shop for coverage and plan for their health care. So those were the general comments that we received. And then there were some specific ones on the plan design. And I think this is where we can open up for discussion. I do know that Brenna is on, and Brenna, you all had a couple of comments on plan designs, and if there's anything that you specifically want to speak to here, I definitely welcome you to do so. But this first comment was about the tiering of drugs. And so currently in this design, you can see that there's generics, preferred brand name drugs, non-preferred brand drugs, and then specialty drugs. And so this is kind of 4 different tiers of copay categories. And the recommendation here is that there be 6 tiers. And Brenna, I don't know if you actually want to let the committee know what those additional tiers are and how you all use them currently and how it might be helpful in the plan design for our standardized plans.
Sure. So the additional 2 tiers that we are advocating for in this instance, and that we've also advocated for with CMS in their relook at the standardized plans on the federal level, is to add preferred generic and preferred and non-preferred specialty. So it's adding a preferred category to generic and specialty to drive utilization to lower cost, equally, effective specialty and generic drugs. And I think especially on the, I think it's less probably critical on the generic side, but more critical on the specialty drug side, where those drugs, have very high price points, that we're able to utilize the cost sharing in such a way to, encourage individuals to use other drugs where lower costs exist.
So that would be in cases where there are alternatives to a particular specialty medication.
Exactly. Yeah. And I mean, it's not advocating for them using a drug that's not going to treat their condition, but just where there is, a comparable specialty drug.
Okay. And in the instance where there is a medication that doesn't have an alternative, would that fall under the sort of brand name specialty, or sorry, it would fall under the preferred specialty category?
I would think so, but I can go back and find out from the pharmacists.
Okay. Well, I think that is a really interesting way of getting at what I think carriers are trying to do in these circumstances, which is manage costs and make sure that we're encouraging patients to use the most cost-effective medications that are available to them, and using the cost-sharing design to do that. Does the committee have anything that they'd like to discuss on this particular recommendation?
Colin, it looks like Jane's hand is raised.
Oh, and I'm sorry, Jane, I've got my screen pulled up, so I'm not able to see when you have your hand raised. So my
That's all
apologies.
right. I was just going to unmute and call out. Yeah, Brenna, I think for me, the question is, especially in the area of specialty drugs, there are different questions I have about generics, but in specialty drugs, I imagine that what's going to start happening is lots of disagreements between providers and carriers over whether something is actually equivalent or not. And I don't know if others share that concern from the committee.
I mean, they typically, Jane, this is Annie. I mean, they typically will do like a step therapy. And so they'll say, you need to try this, right? And then if you have an adverse reaction or it doesn't work, then, I mean, typically a health plan will have you do one or if not two alternative in, more preferred drugs, if you will. And then if they're not effective, then your provider can submit for an exception to that, and then it would be covered. But it is not immediate just because the provider would say, this is what this patient needs. Oftentimes the carriers default to what their step therapy plans are.
But what I'm saying is that a carrier could determine whether something's preferred or non-preferred. And
correct.
Non-preferred could end up being what might be a unique drug. That's the concern I have.
Correct. Right.
I think, Jane, this is Brenna, that's really good feedback. And I'd like to take that back and talk to the team, because with the rise of biosimilars, I think we are seeing a lot of drugs that are, I don't want to say equal, but right, the same drug under a different label. And so if I can get feedback from the pharmacy team on specifically how that works, especially when you're talking about it, would there be instances where there could be a unique drug on the non-preferred drug list for specialty, if that's an instance that could occur?
And Colin, if I can speak, this is Nandini. In situations like this, very often the patient does start off on a generic, and if it doesn't work, or if there's an adverse reaction to the drug, this doesn't stop anybody from prescribing a different level of cost in the drug plan, does it? Do you know what did you understand what I was saying? I mean, if a patient responds adversely to a generic drug,
would there be a cost implication for the individual if they needed to be moved into
a specialty drug? I'm assuming they will, but I'm just kind of laying it out that in both ways, you could be on a specialty drug and have a bad reaction to it and have to be moved on to another one. But in terms of stepping the patient into the lowest cost option with potentially similar outcomes to start with, and then moving up, is there anything in here that would deter either the provider from doing that or the insurance company from paying for it?
I don't think within standardized plan design that we could necessarily get at that. I think it might be more of a formulary issue.
Oh, okay. I get you.
But I don't know. Annie.
That's correct. It is formulary driven, and I mean, unfortunately, if the medication that you can tolerate happens to be a name brand, that's the copay or the cost share that you're going to have to be responsible for. I mean, obviously, a member always has the opportunity to appeal and go through the appeals process, but again, it's going to default to the formulary and where that drug falls on any particular formulary.
So it sounds like the way that this might wind up being impacted through the standardized plan design is that if we had a non-preferred and preferred specialty drug category, two different categories for those types of medications, that there's a potential that somebody might have an adverse reaction to the preferred version and then would have to pay higher amount for the preferred version rather than having those be in a single cost category. So that would be the trade-off.
But it does provide, it does provide an opportunity for there to be a cost variance, which is good because there are obviously people that can tolerate the generic or the preferred, so
Yeah, I agree.
specialty.
So this particular change is something that the federal actuarial value calculator I don't think is able to incorporate, but that we could make part of the pricing AV. And Ksenia, are you? Yeah, it looks like you're still on. Can you help the committee understand kind of what that means in terms of how it affects our AV?
Sure. So the federal AV is a standardized model that really, the way we look at the federal AV calculator is a metal detector, sort of, where all the issuers have to pass the actual value in the federal calculator, right, to make sure they fit within the metal tiers, and here obviously within the turquoise AV tiers. The federal AV calculator does not take into account things like issuer-specific contracting, their experience of their particular population, any regional differences. So particularly for copay style plans, those items become material. So when issuer goes to actually develop pricing for their particular benefit design that already fits within the federal AV calculator, the pricing AV that gets built into the premiums actually reflects those particular issuer specific, market specific parameters and conditions. And so that's where we generally see the differences between the federal actuarial value and the pricing actuarial value. I'm trying to think, Colin, is there anything particular for this question that would trigger differences in actuarial value? And there certainly could be.
In terms
there
of what
anything-
would get entered for the specialty drug category, would it, for the AV calculator, would it be just the preferred side or would it be the non-preferred?
Yeah, so for that, we would need to develop a blending weight of the expected number of claims and allowed costs associated with each sub-tier, and then calculate an effective cost sharing to be entered in the AV calculator.
Okay. Great, thanks for bringing this into the discussion, Brenna, and I think we can, oh, and Jane, I see your hand is up.
Yeah, just Brenna, are you asking, are you wanting this to be the 6 tiers included in the standardized plans? Or when I look at, I think what was sent to us as your initial comments, it was a broader request than that.
I think the 6 drug tiers were specific to inclusion in the standardized plans.
Okay. Thank you.
All right.
So are you already providing 6 tiers in your QHPs?
Also a good question. I will look and see and get back to you.
Okay.
All right, I'm going to move to the next one. And I don't know that we have anybody from Molina on today, but if we do need any follow-ups, I'd be happy to reach out. So Melina suggests that the addition of a deductible for non-preferred drugs where specialty drugs do not have a deductible, um, because they usually don't see specialty and preferred in the same copay, or specialty higher in both subject to deductible, to move. So I think what they're trying to get at with this comment is to say that typically they will price non-preferred brand name drugs in a way where they will be less expensive than the specialty tier. And the committee had a lot of discussion about this last year. We did talk about it during our discussion last month as well. And the reason that the committee wanted to do this was because of the discussion around how people with very high health needs who need access to specialty medications often pay a lot out of pocket in that initial when they actually go to fill a prescription and need that specialty medication. And specifically, Teresa Gomez, who used to be on this committee and is a cancer survivor, explained to the committee what she had to go through to be able to afford these medications, and basically that there wasn't a plan available to her, where she wasn't able to access it through a copay. Basically, all of the coverage was coinsurance, and there often was a deductible applied. So I think the desire of the committee here was to make these medications more accessible to people with higher health needs. Any discussion, or is this something that the committee would like us to work with Wakely on providing options that would change this, or would you like us to continue to move forward with this approach of trying to minimize the out-of-pocket costs for specialty medications?
Yeah, Colin, I do have my hand up, but I think that your explanation makes sense to me.
Okay. Any other discussion from the committee? All right, I'll move on to the next comment. So there was a comment from Western Sky Community Care, which I don't think we have anybody on from Western Sky. What they asked was about maximum out-of-pocket levels, and specifically for this income group between 150 to 200% of the federal poverty level. So right now, the annual out-of-pocket max that's proposed in the standardized plan designs would be about $1,500 for an individual. That would wind up being in that worst case scenario where somebody needs a lot of care during the year and hits that out-of-pocket maximum. That would wind up being about 5 to 7% of their income, depending on where they are in that income range. Most people don't hit the maximum out of pocket, and I think we discussed this with Wakely. They made the point that specifically with copay-based plans, you're less likely to hit the maximum out of pocket. And one thing we were trying to do with this plan in this income range is strike that balance between deductible, maximum out of pocket, and then the copay amounts. And what drives a lot of that initial access to care is how much that copay is in the first place. And so I think within the kind of balance of things here, what we tried to do is have this max out of pocket be kind of in the mid range, what we might see today in the market, and then really minimize the deductible and try to have more lower copay amounts. And so that's what the current design looks like for this. If the committee would like us to look at a couple options where we reduce the max out-of-pocket amount for this plan, it will require us to modify other pieces of the plan design to make sure that we hit that actuarial value target, but we are able to do that if this is something that the committee would like us to explore. And I should say also that in this comment, the question is posed about whether this would lower costs enough to achieve target increases in enrollment. We actually don't have, this committee has never considered enrollment increases and standardized plans as necessarily being drivers of one another. It certainly could be, but a lot of the priorities that were laid out and discussed last time were focused around that cost predictability element. So there haven't been specific target increases in enrollment considered within the standardized plan design.
Colin, I agree we haven't looked at it, but I think it is a question. And, you know, clearly part of what we're trying to do is create a product that people find attractive and thereby choose to enroll on the exchange than on other. And so increasing enrollment would be definitely an issue for me to consider. But, you know, when I look at saying the $1,500 is above the 150% for New Mexicans in that 150% federal poverty level is a significant component of their cost. I'm wondering if some of this discussion comes back to us when we grapple with what happens to premiums as premiums are developed, and you know we get the full picture of what the impact is. I mean, I'm not sure I'm sympathetic to this issue. I just don't know that I want to go around slashing the maximum out of pocket yet. But I'm curious what other committee members think. I don't know what a rational or rational maximum out of pocket would be, one, and two, I do see all of this feeding into increasing our enrollment. I mean, that's a big target for me.
Nandini, this is Annie. I think that it is a good idea for us to see the premium piece of it first, because I believe that raising the maximum out of pocket does have a material impact on premiums. But you also, on the other side of the coin, I think oftentimes when people are looking at health insurance to purchase it, they're not necessarily looking at the maximum out of pocket, right? So I don't know how much that goes into decision making, quite frankly. Oftentimes you see consumers are looking at the copays, right, for maybe even for as much as hospital and primary care and specialty, but not so much the MOOP. So
yeah, I can see that.
And so the main trade-off we would have to make here too, I think premium could be one component of this. The other is just the copay amounts or in the deductible amount and how that would have to adjust to achieve that 1,000 or like a different max out of pocket. I see that both Superintendent Toll and Jane said that it might be worth looking at a $1,000 MOOP. And it's definitely something we could do. Just want to let the committee know that it winds up impacting the other out-of-pocket costs, and potentially it sounds like it additionally could impact the premium as well.
And Paige, I think I answered your question that it's my impression that people look at the copays first versus the MOOP.
Paige, it sounds like Paige agrees. All right, so why don't we circle back to this at the end of today's discussion, and then we can decide if y'all do want us to take a look at that. And when we do a market overview next meeting, we can actually look at what the current plan designs look like and compare against those. And I think that's the other thing to keep in mind today, is that carriers are still permitted to offer non-standardized plans. So there may be plans that do have higher max out of pocket for an income range. Some will have lower. And I think it's good for us to think about what sort of balanced approach we can take where we're not increasing costs on any one particular area too much, and try to hit a middle ground between these different types of out-of-pocket costs. All right, we do have another comment from Blue Cross Blue Shields about the mid-level copay tier. And this is regarding a law that passed a few years ago. And I'm sorry, there's a little bit of overlap in the text here, but I believe it was in 2019, if I'm not mistaken, that HB 81 passed, and it requires that the copay and coinsurance for physical rehabilitation services be no more than what is charged for primary care services. And so in our current design, you can see that there is a discrepancy between these two. And so what we would need to do is make a change in this design to bring occupational and physical therapy into lower copay category so that it matches with primary care. Any questions or discussions on this recommendation?
Just what I put in the comments. I think we should follow the law.
I'm with you there, Jane.
I think that's an unreasonable posture.
Who would?
All right, so we will make those adjustments. And as I noted in here, it's a little hard to see, but this will probably require some additional plan design changes that just result from these out-of-pocket costs being lowered a bit. As I like to say, in this is the balloon where if you push something down on one side, it comes out the other side, and we need to kind of make some balances to make that work. So we'll try to stick within the main parameters that we have here without adjusting things too far beyond where they are right now. All right, another comment from Melina. They say that although ER visits being subject to the deductible is something that is seen in the market, Melina would like to point out that members at lower income levels would find it difficult in an emergency situation to add in a high deductible charge. And this was definitely something that was discussed quite a bit last year about making sure that these services are accessible. So I think that the comment here is actually on the Turquoise 2 plans because we don't have a deductible in the Turquoise 1 plan. You can see that the deductible does apply to the emergency room services for this group. That deductible is $50. So it's pretty limited, but it would be having to hit that deductible and then paying a $30 on top of that. So for an episode that could be for a visit would be $80, depending on how this is ultimately designed. What we could do is remove the deductible from this particular service, but as I noted, that would require other changes, including increasing the max out of pocket or the copays in other categories. Any questions or comments on this particular request? It's one that we're definitely happy to try to work in to see if we can find a way to do this, but I'm sure that's something that the committee is interested in.
Yeah, it took me a minute to kind of soak in that particular comment, Colin. I'm sorry, but I think this is another one of these things where the balance is an issue. I mean, we don't want someone who's in an emergency room to walk out of there because they can't meet a deductible. I don't know whether that's an issue, but I had looked at these copays and thought they weren't unreasonable. And what we were trying to do, if I recall the discussion, was to say we want them to think about going to free primary care or free doctor's office, free in the sense of no copays if you go to the appropriate resource outside of an emergency room, rather than show up in an emergency room for something that doesn't belong in an emergency room. Am I right?
Mhm. Yeah, that was a big part of the conversation, was sort of the design on the emergency room services was intended to encourage people to either use primary care or an urgent care facility if those are available options to them. And so in this category, right, primary care I think would be $5, urgent care would be 10, and then an emergency room visit would be uh, 30, and then subject to that deductible.
Okay.
And I think you're exactly right. We're trying to hit a lot of different balances here. And I see Paige has said, well, a few comments. Looks like Paige asked if we want to incentivize urgent care in this situation. And I think that's part of what's built into this design, is that, urgent care is going to cost you less than going to the emergency room. And so if you have access to those services,
Can I jump in, Colin?
Yeah, go ahead, Paige.
Okay, so here's my overall concern. I see so many of these freestanding urgent care places pop up. And I think to myself, where are these doctors coming from? And I think to myself, probably primary care doctors are getting paid more to do urgent care than primary care. Am I mistaken?
Yes.
What's going on there? Like why are we sort of pushing more towards an urgent care model rather than a primary care model? Or what is the incentive for all of these freestanding urgent care places? And is there anything we can impact through our plan design?
Actually, Paige has raised a very important question. And we're not here to address quality of care. Obviously, we're here to create an insurance product. But the few times I've had to use an urgent care facility, they're not doctors that I saw. They were usually physician assistants. And if there's a doctor in the picture, he wasn't in the building, or she. So there is an issue. And I've heard horror stories also from friends who've gone to urgent care and then ended up having to go to the emergency room anyway. So that's a whole, I don't know that that's our responsibility to deal with, but it is, maybe the superintendent can take that on, because the whole idea of quality in our urgent care, I'm not sure I know who reviews it.
I just
Colin?
wonder if these people are getting paid more, and therefore it incentivizes more of these folks to go into urgent care rather than primary care. And I don't know, the carriers might know a little bit more about that. Like, are there incentives to be had for lowering the costs of urgent care that might perversely impact primary care access?
Hey, Colin, this is David Shaw.
Hi, Director Shaw. Did you have something to weigh in on that point?
Well, just as part of this discussion, I think, as a provider, I want to put this in there. I can't speak for the Albuquerque market, but here in Lovington and across the state, there's a real shortage of primary care providers. And so one of the ways we tried to address it here at Nora Lee, we have a number of primary care providers that have a panel of patients that they take care of, and they address ongoing chronic needs and those kinds of things. But if you need to get in to see your primary care doctor because you have an urgent situation, you may not be able to get in for quite some time. And so we've established, they're within our rural health clinics, but we call them extended hours clinics. They're similar probably to what an urgent care clinic is. And so for those urgent things, that's how we're addressing the physician shortage for people that have urgent needs, is we have those extended hours clinics to address that. So I think it kind of depends on the situation, and part of the issue you can try to build incentives to send people to primary care, but if there's no primary care, I'm not, you're kind of defeating the purpose.
And Colin, this is Annie. I mean, another challenge exists is that many people do not have a primary care physician. And when they're told, well, you need to select a primary care physician, they'll call. And just to set up an appointment and to do that introductory can also often be 4 to 6 months. So then that becomes a barrier to selecting a primary care physician. So people naturally default to an urgent care facility. And, obviously that's not consistent care, right? It's not somebody that continually has your medical record and is looking at your history, which we all know. So, but again, it becomes that natural default because none of the plans require that you select a primary care physician, right? So I think that there's, it is, I don't know about the physicians making more money page. That's, I think that would depend on from carrier to carrier.
Yeah, that is true. I mean, and again, I'm not necessarily talking about the model that's existing in Lovington. I know Lovelace sort of has an after-hours system baked into it, and I think Presbyterian. I'm just looking at the specter of this sort of freestanding ER/urgent care model that seems to be cropping up, and I know has caused some problems in Texas. And I don't know what the incentives are for that. And I don't know if plan design can be involved in realigning those incentives,
Exactly. And yes, I think it's an important issue, but I'm not sure insurance plan design can get into it in the same way.
Yeah, to the extent that
So
it can, I think we've.
Can you remind us of the problem we were trying to address as a part of the plan design?
Yeah, so one was that we did sort of want to get at what Paige was talking about with primary care being lower than urgent care and then that being lower than emergency room. But then the
Lower
balance we were trying to strike was making sure that in those communities, and particularly rural communities that may not have, or that are more likely to have primary care shortages, and even may not always have access to urgent care facilities, that the emergency room costs not be so high that it would be totally cost prohibitive for people. So I think we actually wound up adjusting downwards some of the emergency room service amounts from where they were early on in the plan design process, but that we're trying to strike that middle ground, and this is the approach that we ultimately landed on. So if the committee would like, it's something we can explore in removing that deductible, though I will say that the overall deductible here is $50 since it's not, really high. We tend to see deductibles well over $1,000 and all the way up to 9,100 this year, which wouldn't be able to be the case for this particular plan. But would you all like to see a version of this that doesn't have the deductible applied, or do we feel confident in the plan design as it exists today?
Well, it's hard to know. It really is. Where does this fit with the other plans in terms of the deductible at the federal poverty level, at the FPL levels? Is this comparable to what other plans have currently, or is it higher than most other plans?
I think it's mixed. We have Saharan, who's done a lot of analysis of the existing plans on the marketplace. And Sahara, I don't know if off the top of your head, kind of how this is situated among the current turquoise offerings.
I don't remember the details, but I can gather the information and send them to the committee to look at the ones that are already on the market.
Okay. So maybe we can send that information and have a comparison of the plans that exist today. And you can see sort of how this particular element stacks up.
Yep.
Great. And Director Shaw, did I see you were saying something, or was it just feedback?
Back and forth on conversation.
Well, you're really quiet. I'm not able to hear you.
Oh, I'm sorry. Can you hear me now?
Yeah, that's better.
Sorry about that. Our internet went down, and so I'm having to use my phone. So I apologize. So the question is about the urgent care deductible. Is that?
It would be the emergency room services deductible for this Turquoise 2 plan.
Yeah. I still think there needs to be a deductible there.
And that just being like a way of incentivizing people to use those other forms of services that they might be able to use that are lower cost.
Yes.
Is that the committee's agreement on that?
I can support that. This is Annie.
And this is Steven. I definitely support that as well.
I'm not sure I know everybody on the call. Stephen, do you mind introducing yourself?
Yeah, no problem. I'm Steven Stoddard, and I'm the Executive Director with the New Mexico Rural Hospital Network.
Oh, okay.
Great, thanks for being on, Stephen. So it sounds like at least 2 members are okay, 2 members of the committee and at least 1 member of the public supporting that.
So Colin,
Hmm?
just to explain the reason why I feel that way, at least in my market, there's an alternative, right? So, I can go to the emergency room or I can go to the extended hours clinic. And so, and I know there were questions about what an extended hours clinic or urgent care clinic has. I can only speak for my facility, but we have doctors and mid-levels both in those facilities.
Mhm.
And the cost is definitely less in the extended hours clinic as opposed to the ER.
Mhm.
Well, yeah, I think perhaps we should just, I mean, my suggestion is we go with this, but I think we do need to bookmark the issue of how urgent care facilities function in various markets, which is not the role of this committee perhaps, but somebody needs to take a look at it and make sure that, there is actually, the whole purpose of this is to say, let's have people go to the lowest level of care they can get with the hope that they will then find a way to stay out of the emergency room for longer periods of time. And so we've got to go with that. I think we may want, somebody else needs to take a look at how many people go to the emergency room after visiting an urgent care facility within a week, for example. But that's not our job at the way I see it right now. But I think given the objectives we had, the way you've laid it out is probably the way I think we should go. Let's get it costed out. Let's get it looked at, and then let's figure out a way of finding someone to do this other work, about whether what we are intending with this model can work in all of the markets we're talking about. I think it would work in David's market. I mean, the way he's described it is perfect. But in the Albuquerque area, I'm not sure it does.
And this is Jane. I'm trying to understand what it is we would be looking at, so that there would still be a copay, but no deductible beyond that applied. Is that under Turquoise 2? Is that the proposal?
I believe so, and I think actually Dominic from Molina has joined us. And Dominic, I know this is a question that you all have proposed, and I think what you're getting at here is removing the deductible from that emergency service category for turquoise 2. Is there anything that you want to speak to about this now that we have you on?
Thank you, Colin. Nothing right now. Sorry, I joined in the middle of this. I still have the old link, unfortunately, but I don't have. I'm just trying to kind of digest as I'm coming on now. But I'd have to go back and kind of go through some of the questions we had submitted to get those kind of ready in front of me right now.
Okay. Well, I think, you know, if we by
Colin,
keeping, oh, sorry,
Colin,
Jane.
yeah, I just have to say, I don't think the difference between, you know, the 30 and the 50, I see it in the turquoise 3 and 4 is where we really could get some significant issues. So maybe I'm not understanding this well enough.
That could be the case. I guess it depends on how we're defining lower income level here, right? I think I figured that it was not this lowest income level since we did not have a deductible there. But if we're counting kind of the full up to 300% FPL amount as it low income, then it does impact these two groups as well. And I think the one thing I would say is for these groups, if we were to remove the deductible on emergency room services, we'd likely have to increase the copays across the board or increase the deductible for the services that it currently is applying to, or increase the maximum out of pocket. So there's no easy trade-off with these, but it's something we can explore if the committee does want us to. All right, I am going to move on to the next one. And I think, Dominic, if you wouldn't mind getting back to us about additional thoughts on that, that would be very helpful. And I'll share the video of this for the piece of the meeting that you missed, and apologies for the confusion with the old link.
Thank you, Colin.
All right, so we did have Western Sky Community Care, and I don't think that Quinn is on, but a question about whether we should consider a standardized plan design for the bronze level of coverage. Right now, we're just looking at the silver and gold. He said, or they said that this may provide an additional affordable option for certain consumers, including higher income consumers who are price conscious. So give the committee a little bit of background on this. Right now, we only have one carrier offering bronze level coverage on the marketplace. It seems that the carriers have shifted to the silver and gold options. There is an option within our let's see, there's the ability to create a bronze standardized option. However, we can't require carriers to offer that if they aren't offering bronze plans. So if the other carriers didn't want to offer a standardized health plan, even if we adopted one, then we wouldn't be able to require the other carriers to do so. So that's one thing to keep in mind about this. I think the reason the committee wasn't considering a bronze option is that we were trying to look towards these new plans with the out-of-pocket assistance applied to them, which are only the silver and gold plans that typically do have lower out-of-pocket costs than the bronze options. So any discussion from the committee on this particular point?
Well, I had just typed in, that second point I strongly agree with.
One other thing that Wakely had raised for us when we discussed this with them is that if we wanted to make this a copay plan, the copays would have to be so high. to make the actuarial value amounts work. And so that could be a real challenge in making this an option that people would actually want to enroll in. So I guess the key question for the committee, if there isn't any discussion, is this an avenue that we want to go down, or do we want to continue just focusing on the silver and gold coverage that provides more robust financial protection? Jane says silver and gold, and
Yeah, I would say silver and gold. Let's take this one step at a time. I don't see a problem with doing this down the road, but I'd rather get going on these on the ones that we focused on, especially because this is an appealing option for high income consumers who are price conscious. Well, they have choices, and they already have choices, I think. So I'm not as I don't see the urgency in going into this now, but perhaps down the road, that would be, that would be a community that might buy off the exchange.
Yeah, I agree putting that off for now.
I agree as well.
right. Let's see, and then we had a comment that's not related directly to the plan design, but a request from Blue Cross Blue Shield about continuing to be able to offer 2 non-standardized silver tier plans in addition to the standardized silver tier plans to maintain those options that are still there. I certainly don't see an issue with this. I think given that we're introducing this new plan, we wouldn't want to be replacing any existing plans on the market. And Superintendent, I know we didn't have a chance to discuss this, but if I don't know if you had any other anything beyond what I already said to add.
No, I agree with you. And I don't see any problem either.
Okay. All right, and then as I noted, we did have some questions that came through from the carriers. I don't think we had any specific questions from non-carrier public comments, but we're in the process of finalizing some responses to those, and we'll send those to the committee for your consideration. And just wanted to let you all know that we would make sure to get that to you this week.
Okay, sounds good.
Okay. So I think we have some direction now on what we need to provide to the committee the next time that we meet. And here I'm going to stop sharing my screen so we can see each other again. And I'll pull up the agenda. All right, so I think we actually kind of got to this during the discussion, but the request for impact of these modifications, we'll refer back to this meeting on what y'all wanted us to take a look at. And then next meeting, we'll be able to present those updated models to you. There are a few of these there's going to be some cross pressures on, so we'll try to develop a few different options so that there's a lot for the committee to chew on and discuss. The next meeting that Lexis had sent out was for December 8th from 2 to 3, and certainly request public comments based on today's discussion, and we can make sure to present those next time around too. We'll also provide that market overview during that upcoming meeting. But why don't we take some time now for the committee discussion, and if there's anything else that we may not have got to in the review of the comments that y'all wanted to discuss today.
Colin, I just put my hand up, but if you could summarize what you're going to be looking at, kind of what we decided today.
Sure. Let me jump back over to the presentation then. And I was planning to go back through this video to make sure that I captured all the ones that we had discussed. Okay, can you see it again? Okay, the first one was around the additional tiers. We can definitely create some additional tiers for the specialty drugs. I'm not, it sounded like from what Ksenia said that we would have to have some sort of weighting in how we do that for the actuarial value calculator, but we could produce something, at least the actual plan design for that, and have that ready for the committee to look at next week. Or sorry, at the next meeting.
As part of that, I still have a concern that on specialty drugs where it's a little bit different than preferred brand drugs. And I'd like to get a sense of how common it is for carriers to do the preferred and non-preferred under the specialty drugs and how that has been experienced by providers and patients.
Mhm. Okay, so maybe before we try to design anything, perhaps we could reach out to carriers and providers about that and pharmacists and get input on that specific question about this tiering strategy and how it's affected providers.
Yeah, and if it's really done routinely now, or if this is, kind of emerging and we don't really have the data yet on those impacts.
Okay. Can definitely do that.
I'm not sure I see the need on the generics. I'm not as persuaded on that, but maybe I'm missing something.
Sounded like that may have been what Brenda had noted too, that it's more effective tool on the specialty side than on generic side. So I think we would be considering this as a 5-tier instead of 6-tier if we were at it. All right. Second piece was on specialty drugs again, and how these match up. I think we actually settled on this one on that the existing approach and the rationale for it was still supported by the committee. So we wouldn't do any additional testing on this. I think there was a request here to take a look at what the impact of reducing this to $1,000 might be, and what would have to change, and considering some potential premium impacts there as well. We'll be modifying this to be in alignment with state law to make sure that occupational and physical therapy are in the same copay category and same copay amounts as primary care. And I think we ultimately opted against making any specific changes around the emergency room not being subject to the deductible. I believe that those were the only ones. The bronze was decided against, and this is a kind of secondary tier policy choices that won't directly impact standardized plans. Everything look okay there, Jane? Was there anything I missed?
No, that was a helpful summary. I just want to make sure everybody is, on this working group is supporting that, or that's the consensus. I'm good with those.
Okay. And I'm assuming if there's no objections from the committee after reviewing that those are the directions moving forward for what you'd like to see during our next meeting. All right.
Looks
Hearing
good to
no
me.
objections then. I don't believe we have anything else. So I believe that Lexi will be sending out the invitation to the next meeting. It will be posted on the webpage. And I did want to make sure before we jump off to send that webpage in the chat because Jane, you had noted that the link didn't work for you or you weren't able to find it. So let me make sure to do that before we go.
Somebody else has
Oh,
their
and I'm
hand.
sorry, opportunity for public comment. That's the first thing that we need to do before signing off. Thanks, Jane. Any members of the public that would like to make public comment?
Somebody's hand is raised that I can see. DG?
Dominic Griego.
Yes,
Dominic.
thank you. So I just wanted to kind of circle back. I think I had seen a couple people fall off, unfortunately, already. But as I as I jumped in and I was reading what was on the screen there, I wanted to kind of get some better understanding of what the question was for Molina. It looked like you had some questions regarding the either the the suggestion of the addition of a deductible for the non-preferred drugs, um, or was it regarding the ER visit being subject to a deductible? Because like I said, reading what was on the screen and kind of following along with the discussion was a little bit much for me when I joined. So, but I also have Sonia for support on the call as well. So, but wanted to kind of circle back and see exactly what you were looking for, Colin.
Sure, I think there were two, and I can definitely pull them up right now. And then if it might just be helpful for you all to speak in your own words about the rationale for the suggestions that you made. This is the first one.
Oh.
And I think the easiest way to summarize this discussion that that we had about this was the desire to have primary care be the lowest tier, I'm sorry, like primary care in the lowest tier, an urgent care facility kind of being in the next tier, and then emergency room services being in the higher tier because those are higher cost services, and we want to encourage people to use those lower costs and more appropriate services for those needs, while striking that balance of not putting that care out of reach for people who really do need those services. And so if you all would like to then speak to maybe first how you're defining low income for this comment, and then second,
So,
what we
Colin,
would
this
like
is
to do.
this is Sonia Pinate from Molina, corporate product development. So what we were looking at in this is that we were just suggesting that a member that is in this turquoise plans or that would qualify for the SOPA, they would be in these lower cost share, right? The lower income levels. If you take an example like the emergency room services at $1,500 for $100 per, and then subject to deductible, that member then goes in and pretty much would have to pay about a $1,500 for that first visit, right? Because we know the emergency services are highly expensive. So I understand deterring folks are trying to teach and move away from emergency room services for anything that's, you know, urgent care related. So that's why you put urgent care within something that could be attainable. So we do something similar to that. But in the emergency room services, just calling out that that is something high that somebody could potentially on their first ER visit, right, have to shell at something like $1,500 in that tier, $750 on the others, 50. You know, you get somewhere closer, but those are even lower income folks, right? So we wanted to call that out and just make you aware of that, and just know that, you know, we had a concern or a question about that.
Okay, that's helpful. And do you have an alternative approach to
What
this for the committee to consider?
So once you get those AVs in line closer to the PT, OT, ST because of the regulation, right? So once you get there, removing that deductible, we understand those high copays, you know, sometimes that helps the AV swing because ER visit is a major swing in the AVs when we're calculating. We would suggest doing something else in there. We can, off the top of my head, I couldn't give you suggestions without looking at the AV, but we can definitely send those your way if you'd like. More than willing. So I'll send you some examples that we would think of, Colin.
Okay.
And then we had anything else about this? I heard there was a lively discussion that I missed. I'm sorry, I missed that.
No worries. I'll send you the video so that you can go back and listen in. It was very riveting. Yeah. This was the other question I think that you all had submitted and a recommendation on this. So I don't know if that's something that you want to speak to your perspective for the committee's benefit.
Sure, I'll talk about our overall perspective. I don't have my pharmacy counterpart on with me, but we do have a concern in regards to making that non-preferred brand drug a higher cost share than our specialty drugs, where specialty drugs are usually the highest cost share in that tier structure. I did hear as I was joining that there is a suggestion for a six tier prescription drug. Molina does not actually have a 6-tier prescription drug that we offer in any of our states at the moment. Not that we are advocating for not having that, but we would like to see the information in regards to provider abrasion or pharmacy issues in regards to a 6-tier structure and what that's offering, you know, any person involved in that, you know, front or back. Our suggestion here is just that we move up that specialty drug. That'll flip your AV also. That'll give more folks access to. We know we want to move them to like generic drugs or to preferred brand drugs, right? But we don't want to move them to specialty drugs at that point, right? We'd want them to look at that formulary in those other tier structures.
Yeah, and I think what we
Can I ask a question? Can I ask
Sure.
about that? Are you saying that some specialty drugs are the same as preferred brand drugs? And that this is creating an incentive to use the specialty drugs?
It looks like it's incentivizing from our perspective when you have that lower cost share. Not to say that specialty drugs and preferred brand drugs would be the exact same for the exact same ailment that would be pushing them there. But I would have to get pharmacy on the call to dig deeper into that question, Jane, which I'm glad to do to get their perspective.
Because that would be the only I mean, that's the only way in which I think the argument about incentives makes sense to me.
Yep, definitely. I can definitely get their narrative to you. No problem. And that's all I have, Colin, on those two for Molina.
Okay, thank you, Sonia.
No problem.
Any other public comments? All right, well, we can give everybody 4 minutes back. We will post this on beWellnm's landing page, which did I put it in the chat? I don't think I did yet. Sorry. Too many screens. All right, the landing page is there in the chat if you do want to access that page, and will be updated with the slides that were presented today along with login information for the next meeting. All right, thank you, everybody. Have a great rest of the day.
Thank you.
Thank you.
Thanks, Colin. Bye.
Have a good one.